Thank you for that introduction, Dr. Dietz. Yeah, I guess with all this technology, I hope you don't lose faith in the technology I hope to show you. But in the process, I think you learned a little more about me in that you saw my file called Nearly Trash, so now you know that I'm a hoarder. I don't throw anything much away. Now, what I'd like to talk to you about is what's really of interest to me, and I think to a lot of people in the medical field, and that is the neurodegenerative diseases, because, and particularly Parkinson's disease, because it's probably one of the most common neurodegenerative diseases aside from Alzheimer's. And we think that probably if we can find the underlying cause of one or the other, we would be able to solve a lot of the degenerative problems of aging. Let's see. Okay. Well, so James Parkinson's from England back in the early 1800s. He was a prolific writer of politics as well as of medicine, but he wrote a pivotal piece on shaking palsy, and he did this purely an observational, observing people walking down the street and very little contact with them, but he was a physician. And so he described this that long ago. And he described it as a disease of involuntary movements with lessened muscular power, and so therefore the term paralysis, although it's not really a true paralysis. And then in parts that are not in action, so basically at rest, and with a propensity to bend the trunk forward, so they have some problems with balance, and they tend to go from a walking to a running pace. And most of the patients are not affected in their thinking like Alzheimer's would be. The group that is commonly affected is those that are above 60, but it can occur in younger age group in the 40s and of course a lot older. But it's more common in men, and it does affect about 1 million people in North America. Now, the signs that we look for currently, and probably have been important to note that this disease is not really tested well by any sort of scan. We don't make the diagnosis by MRI or CAT scan necessarily, but we diagnose it as most clinicians do by examining the patient and making our observations. So the resting tremor is most important. It's a shaking of the limbs that occurs when the person is not doing anything. They're usually sitting and watching TV. And that's as opposed to other sorts of tremors, which I'll show you at the end of the talk. And rigidity is another feature, which is the stiffness of the limbs, and that can be examined. But patients will often describe it as a feeling of muscular stiffness, and sometimes they're misdiagnosed as having arthritis. The term akinesia is related to movement. Akinesia is a Greek for no movement, or we use the term bradykinesia, which means slow movement. And there's impaired postural reflexes, which is a little more difficult to explain, but basically our postural reflexes keep us standing upright, and these patients tend to fall easily. So for many years, the hallmark has been the microscopic finding of Lewy body. And so what is a Lewy body? We'll get into that. But it's been principally the pathologic hallmark of Parkinson's. And it's seen in the substantia nigra cells, which is basically where the damage is done. So this is what a Lewy body looks like on H&E stain when you stain it. And basically, this is a cartoon just to show you what it kind of looks like. And it is in the cytoplasm, and it's obviously large and kind of disorganized as opposed to other parts of the cellular structure. Well, as far as clinical symptoms, we tend to stage it. We like to stage things. One of the simpler stages is 1 through 5, developed by Hone and Yar back in the 1940s and 50s. There's a new scale that's called the United Parkinson's Disease Rating Scale, and that's really used for research. But in the clinical setting, we easily could put patients into 5 clinical stages. And the first is stage 1, in which the symptoms are mild and usually on one side. And so one other feature is that Parkinson's disease is usually a one-sided disease in the beginning. And it usually presents as tremor, as this still picture tries to depict. But I hope to show you some some videos later. Stage 2 then begins, is basically affecting both sides, so that's easy to remember. And there's a little more disability, and you can see the patients depicted as bending a little bit forward, and so their posture and gait are affected. And then stage 3 comes more impairment in the balance, and you can see their center of gravity becomes pulled forward, and they tend to have more dysfunction and more falling. Stage 4, devices used to get around with, like canes and walkers, become necessary. And interestingly, the tremor may be less because what happens is that the rigidity becomes more pronounced, and so their limbs become more stiff, and the tremor doesn't is not as evident, but it's still there. And of course, stage 5 is considered to be the invalid stage, usually bedridden or wheelchair-ridden. They can't walk they can't walk safely. So what causes Parkinson's disease? And that's really the million-dollar question that everybody is trying to figure out. And if we had that answer, we could cure it. Right now, there's no cure for Alzheimer's or for Parkinson's, but we can still do a lot. And I stress that with my patients because I think it's important to give hope. And I don't mean false hope, but I mean hope that probably in the next 5 to 10 years in your all's career, there will be a cure for Parkinson's. So I think that's an exciting thing to look forward to as prospective healthcare students. So there's several causes. There's been some consideration that maybe this is a normal aging process, but I think that's been pretty much dispelled as a normal aging process, because what happens with Parkinson's disease is that there is a period of time that the cells in the substantia nigra, which form the chemical dopamine, become less efficient. Or they basically drop off and die. And when we reach about 25% of our original number of cells, massive cells in the brain, that's when the symptoms start to show. And this shows the correlation between how long of a lag period, or latent period, I should say, that you begin having this degenerative process. And this is usually about 5 to 10 years. So this is a key period that we hope to be able to establish in the future, because as we develop treatments that can cure, we want to find patients in this area here before symptoms start. But before then, it may not be as important. Right now, we're capturing them, of course, when the symptoms start to appear, and as their cells continue to die, we see more and more symptoms. That's the 5 stages. And again, this is an early study that showed that those people with Parkinson's versus those people with normal aging are definitely on a different curve of dopamine loss. So it's not just an aging process. And this next slide shows the area that is really the focus of attention for Parkinson's, as opposed to Alzheimer's, I'll say, which is more of a widespread cortical problem. So Parkinson's disease is a disease where the pathology is in the basal ganglia, which is in the deep part of the brain. And these structures here in the deep part of the brain really affect movement. They coordinate movement, as opposed to the cortex, which initiates movement. And we'll talk a little bit about that. And this is a little bit more realistic look, although it is on a slide, so it's not living, obviously. This is a stained slice of the brain. And it shows the cortex. And it shows the internal capsule where the fibers come through that go down to the spinal cord. It shows the putamen and the globus pallidus, which are important structures in this whole process. This is another slide showing how complex the connections can be, and these are an attempt to simplify it.